So this is, I'm going to talk to you about our BladderPath trial and the latest data that we presented from it, which we showed at ESMO last week in one of the oral sessions. So slightly weirdly, I'm going to start by talking about breast cancer. And the reason I'm going to talk about breast cancer is because there's been big changes quite a while ago now in breast cancer care, which I think are coming our way in bladder cancer, and you'll see why. So for a long time, the standard treatment for breast cancer was radical mastectomy. And over the course of the 20th century, the operation got more and more and more radical until around about the 1980s, where surgery began to get less radical because it got more multimodality, the management of breast cancer. So various things were published: adjuvant radiotherapy, hormones, chemo, HER2 targeting, aromatase inhibitors, various things. And the death rate fell in parallel with the surgical workload decreasing and changing. So surgery went from these very radical operations where the whole chest wall was being demolished to really very limited lumpectomies with a big emphasis on cosmesis. And I think this is where we are rapidly heading with bladder cancer now. We're heading from an era where we're going to debate whether we should be taking the lymph nodes out, the bladder, to a much more conservative approach where the aim is to either preserve the bladder completely or to treat completely just with drugs. And in order to do that, you need to improve the systemic therapies. Now, there's not time to do a talk on systemic therapies here, but I'm just going to highlight two things: checkpoint inhibition. These drugs, very active and completely new mechanism of action. This is now 10 years ago. Tom Powell's published this very key paper in Nature. And drugs like enfortumab vedotin. And we saw a whole load of new antibody drug conjugates at ESMO, all very active. So this is the first, almost certainly, of many drugs. And if you put those things together, the response rates are spectacular. And in metastatic disease, the response rates are dramatic, doubling of median survival. But then really strikingly, if you look at the EV303 trial, which was presented at ESMO last week, this was preoperative neoadjuvant therapy, amazing results. So a hazard ratio for overall survival of under 0.5, but really very strikingly this. You've got pathological complete response rates somewhere near 60%. So when we've got drugs that are going to debulk and treat bladder cancers this effectively, and these are in platinum unfit patients, it's very clear that we need to be rethinking everything else we're doing as well, because it really makes debulking much less important if you've got drugs that will, at the same time as debulking the primary, treat the metastatic spread. So we can hypothesize that we're going to be heading for a pathway that looks very different, where we can use novel imaging and biomarkers to enhance decision-making. And as part of a de-escalation strategy, and I know Alberta is going to talk next about bladder preservation with chemo-RT, we can look at taking a lot of elements of the current pathway out because they will become redundant when faced with drugs that just work so much better. So again, MRI is something that is very well established in prostate, less well established in bladder, but just to emphasize, these are just some of the images from one of our papers on the topic. You get very clear images of bladder tumors, and you can see between this one, which is a non-invasive tumor where you've got bladder wall preserved, and this one, which is an invasive tumor where it's clearly gone, that you can get very clear diagnostic information from a TUR, from an MRI, with therefore removing the need to pathologically stage. You can stage with imaging exactly as we do for pretty much every other cancer, to be honest. That also raises the question of how much do we need for histology. So we know that generally we're happy with a biopsy, not with a debulking of grams and grams of tissue. So you can get material from a biopsy. Now you're going to say, but you can't properly profile the tumor. But I'm going to argue that you can. So this is data from one of my trials where we've we've looked at tumor DNA, and I'll come back to that. But more specifically, we've looked at expression profiling the RNA from the TURBT chippings. And what we can do is that we can split it up into all the various, these are the molecular consensus subtypes, basal, squamous, luminal, and so on. This is on a single 5-micron slice of tissue. We don't need grams and grams of tissue. We can do it on a very small amount of tissue. And these sorts of technologies are rapidly coming. If we look at tumor DNA, you can detect tumor DNA in blood and even more easily in urine. So pretty much all muscle-invasive tumors, you can completely genotype the tumor from 50 mils of urine. You don't need a single cell, let alone a chipping. So just to show you some data that we published a few years ago now, this is targeted deep sequencing. We had about 1,000 patients. We sequenced the tumors. We then went and looked to see whether, with a panel we designed from the tumor sequencing, we could identify the same mutations either from the urine or from the urine pellets that we collected at the same time as the primary tumor samples. So just to show you, for a whole range of gene mutations that we detected, we could detect them in the tumor tissue in dark green, we could detect them in the pellet, and we could detect them in the urine pretty much 100% of the time. So for each of these, you can see there's very high concordance. So you can get a lot of profiling information from a very small amount of tissue and urine. Also, you can use urinary DNA as a response marker. So there's not time to go into this in too much detail, but this is data that Andrea Necci presented from the Sunrise 4 trial at ESMO last week. The details of the trial don't matter. What matters is that there was a very close correlation between the detection of urinary DNA and the pathological confirmation of a complete response. So you've got a very sensitive tool for monitoring response without doing a cystoscopy. You can do it on urine. It means the patient doesn't need to come to the hospital. You collect the urine, send it in. And for DNA, circulating tumor DNA, you've got the option of using that to try and guide your treatment. So the hypothesis here is that if you've got significant detected tumor DNA, you've almost certainly got metastatic disease and you'll benefit from adjuvant treatment. So again, Tom Powles again presented these data last week at ESMO, which was using ctDNA positivity as a selection criteria for adjuvant therapy. So the ctDNA negative patients do very well. They weren't randomized in this part of the trial, but they were in an earlier one. Whereas the ctDNA positive ones do much worse. So they've got occult metastatic disease, and they benefit from adjuvant atezolizumab. And there's a lot of this sort of data. Again, there's not time to go through all of it. So that's the sort of general background to liquid biomarkers. So now going back to MRI, if you were going to redesign the pathway, you'd say that you want to separate these two things early on, because for these ones, you want to go straight to TURBT. But for these ones, you don't really need a TURBT. You need to get enough tissue and imaging to satisfy yourself of the stage. And then you need to get on with the correct treatment, whether it's surgery or radiotherapy or chemotherapy or palliative care indeed. You don't need to take all of the bladder tumor out in order to make those decisions. You might need to take some of it out to look for CIS, for example, or to control bleeding in the short term. So how do you separate them? So there's an MRI classification system called VIRADS, and some of my co-authors on the bladder path paper are also authors on the VIRADS papers. So this is general background. I don't need to go through this now, actually. This is my slides from ESMO. So the bladder path trial was an open-label, multi-stage, randomized trial investigating whether if we added an MRI in patients who we thought might have muscle-invasive disease, we weren't interested in the accuracy of MRI directly. We were interested in what impact it had on the time to radical treatment. And basically, anybody attending the Hematuria Clinic who had a flexible cystoscopy and a bladder mass was eligible for recruitment. They were randomized to either standard care, TURBT, or pathway 2, where if you thought they might be muscle invasive, you got an MRI. So if you were confident it was non-muscle invasive, you just went straight to TURBT. That was about half of the patients. Where there was doubt, about half of the patients, you got randomized to having an MRI. And we had originally intended to do a biopsy only associated with the MRI, but in fact, most of the surgeons felt that they still needed to do some sort of TURBT. So, but that didn't count as correct treatment. Okay, so this is the design. It's quite complicated. Patients were split into probable NMIBC and possible MIBC. On the control arm, they all got a TURBT anyway. On the experimental arm, these ones went straight to TURBT. Now, some of them would turn out to be muscle invasive, of course. Where there was doubt, they got the MRI, which then separated them. It turned out it was about 50% of the patients were possible muscle invasive, and it was about a 50-50 split downstream of that on the basis of the MRI scan. So, 3 parts to the trial. The feasibility part, and as part of that, we wanted to assess how good people were at flexible cystoscopy in terms of identifying non-invasive tumours, and whether it was feasible to incorporate it in the pathway in a multi-stage setting. So we'd set up Likert scales laminated up in theatre in the participating centres, 15 sites, and just illustrating pictures of what sorts of things we thought would be safely classified as non-invasive and what sorts of things should be classified as potentially muscle invasive. And basically, it worked very well. So this is patients that the clinicians thought were probably non-muscle invasive. So you can see 72, 71 in the randomization, and then 32, 34. So about half of the patients, they were very confident they were non-muscle invasive, and they were pretty much 100% right. There were a couple of muscle invasive tumors in here. Overwhelmingly, they were right. If you look at it the other way around, though, if you look at the patients they thought were possibly muscle invasive, on the control arm, they all went to TURBT, and they split just under 50-50 like this. On the experimental arm, the same split. The MRI, again, split them pretty much in half, roughly half non-muscle invasive, and roughly the other half muscle invasive. Now, some of these turned out to be non-invasive, and I'll come back to that. So the outcomes I'm going to show you now are the longer-term outcomes. So we had an intermediate stage where what we wanted to see was what it did to the time to treatment. And so 17 hospitals open to recruitment, 15 recruited in the end, 143 patients randomized. And we published 2 papers on this, the more recent one being this year. And the time to definitive treatment for muscle-invasive bladder cancer came down from around about 100 days to around about 45 days. That's all published. And this just shows you that in more detail, with no impact whatsoever on the rest of the patients. So if we look at time to correct treatment for non-muscle invasive bladder cancer, this was fast and the same on both arms. The delays come in the muscle invasive pathway, not the non-invasive pathway. I mentioned that there were patients who went to cystectomy with non-invasive disease, and just looking into the TURBTs in more detail, there was a range of TURBTs done on the MRI arm, lack of confidence, histological variance, CIS, and so on, just as listed, or to debulk the tumour. But when we go into the cystectomies, we can see that the cystectomies are evenly split for the non-invasive cystectomies between pathway 1 and pathway 2. It turned out nobody had a cystectomy without a TURBT first. So the surgeons were clearly very careful to be sure that if they were doing a non-invasive disease cystectomy, because, for example, there was very extensive disease and there was a non-functioning bladder, that they had an accurate stage. Nobody had a cystectomy by mistake, if you like, which I think is really, really important. Just stating that. So the final bit, which we showed at ESMO last week, was what the impact of all of this pathway was on progression-free and overall survival. Now, this is underpowered because the trial was killed dead by COVID, unfortunately. We reviewed the causes of death, and we therefore saw COVID deaths. But also we saw significant numbers of cardiorespiratory deaths, heart attacks, strokes, chronic pulmonary disease. These are lifelong smokers. They get these diseases. They also get other smoking-related cancers. And you can see all of this is broadly evenly distributed, and they get other cancers as well. So around 40% or so of the deaths were not bladder cancer. But you can see there's a very striking imbalance in the bladder cancer deaths in favor of the MRI pathway. So how does this break out down? So we looked at 3 things: progression-free survival, bladder cancer-specific survival, and overall survival. And so on all of these, the blue is the MRI and the red is the standard of care pathway. So the hazard ratio for this is less than 1, but the confidence intervals cross 1. But you can see this curve is very consistently above the standard pathway. If we break it down, there's not really convincing differences, though. Maybe this one's looking a bit better than this one. However, when we look at bladder cancer-specific survival, we now see that the hazard ratio is still less than 1, and that the confidence intervals do not include 1. This is statistically significant. And if we break this down, by non-invasive and invasive, we can see that there's a survival advantage in the muscle-invasive bladder cancer patients, i.e., if you treat them quicker, they have better outcomes. This is not a great surprise, but the effect is big. And if we look at the overall survival, again, the hazard ratio is less than 1, shown at the bottom. Because it's diluted by deaths from other causes, the p-value is not significant, but you can still see that there's a very clear separation of the muscle-invasive curves. So our summary from this was that there are strong trends for improvements in all of the key trial metrics. It was feasible, it had a big impact on time to treatment, it didn't have an adverse impact on time to treatment for the non-invasive patients, whilst improving the muscle-invasive ones. If we'd been classifying patients incorrectly, because the MRI got the staging wrong, you'd predict that would impact on the subsequent clinical outcomes adversely. But actually what we see is exactly the opposite. Whatever the staging accuracy or inaccuracy of the MRI, the overall effect was to improve the clinical outcomes in the muscle-invasive patients in particular, and that was statistically significant for bladder cancer-specific survival on the MRI pathway. So we think these are really important data. We know MRI has been transformational in prostate cancer care. You make better decisions if you have accurate imaging before you start sticking needles or surgical instruments into people. There's absolutely no reason to think it should be different for bladder cancer. Thank you for your attention.